Hi, everybody. Welcome. Hi, welcome to a Wednesday afternoon PCNA webinar. Oh, hello, Emily. Hi, Julie. Hi, Louise. Hi, Jess. Hi, Glennis. Welcome, everybody. Thank you for being here. Hi, Jess. Hi, Christina. Hi, Belinda. This is a big crowd. This is nice. Thanks, everyone, for being here. Hi there. Hi, Abdul. Hi, Louise. Oh, hi, Beck. Beck, I know is in Catherine, aren't you? Is that right? Oh, I'm proud of myself for remembering that. Welcome, everybody. While we're going to give everyone just a minute or two to join us, if you wouldn't mind popping in the chat where you are and your name and what you do, that's great, because then we know who is here. Who have we got? So we've got Louise. Thanks for adding that, Louise. Hi, Louise. We've got Abdul. Thank you for coming, Abdul. Who's going to be next to put where they are in the chat? I can see Christine Boys. Hi, Christine. And there's Jess Brown from Melbourne. Hi, Jess. Hi, Fred from Alice. Hi, Fred. Fred's been here before. Hi, Beck. How are you going? Beck from Catherine. I'm very proud to say I'm living in Darwin now, so I can represent NT.
Yay, welcome.
Christina from Melbourne, thank you for being here. Louise, consultant from Adelaide Hills Community Service. Thank you for coming, Christina. Louise. So let's give everyone one more minute. Hi, Abdul from Singapore. But you've recently moved to Orange. Oh, that's cool. Welcome. It's such a good way of getting everyone across Australia together. You'd never do it otherwise. So great. Thank you very much, everyone, for coming. And Christine Boyce. And Belinda from Melbourne City Mission. Hi, Belinda. So let's get going. So welcome to another PCNA Wednesday afternoon webinar. And I'm very grateful that you've all joined us. This one is going to be about nausea, and I'm going to introduce you to Jenny McKenzie a little bit later, but we're very grateful that Jen has come to share her wisdom. So before we start, I'll do an acknowledgement of country. So PCNA would like to begin by acknowledging the traditional owners of the land that we're joining from today. And each of us will have a different land, but I'm on the land of the Larrakia people. I pay my respects to their elders, past and present, and recognise their ongoing connection to this land and the water and the community. I extend my respect to any Aboriginal and Torres Strait Islanders who are joining us today. And we at PCNA hope that we can continue to learn and walk alongside First Nations communities, especially as we provide compassionate and culturally safe care. So thank you for being here, everyone. So I'm now going to introduce you to Jenny McKenzie. And then I'm just going to give you, before she starts talking, I'm just quickly going to give you a few ground rules, but I think we're all regulars now, so you probably already know them. It's not about Jen and I, but Jen and I worked together 10 years ago. And Jenny is a nurse practitioner, and she became a nurse practitioner in 2026 and works in the Murrumbidgee Local Health District as a nurse practitioner. She's on a number of important palliative care and end-of-life committees, and she was actually awarded the New South Wales Health Member of the Employee of the Year a number of years back. So go Jen, she's very important and an instrumental person across the rural regional space in New South Wales. So thank you, Jen, for being here. Do you want to give us a wave? So just before Jen, go Jen.
Yeah, no, that's all right. Thank you, and it's lovely to see so many people from across Australia and different places. And hopefully something today resonates, or you can ask questions, whatever. I can talk with a mouthful of mud underwater. Yeah. So do you want me to take it away, Sarah?
Well, before you do, just
I'll shut up now.
Don't. We just if you can, pop your camera on because it just feels way nicer to be talking to a person. Turn your microphones off if you can. And as Jen is talking, please think of questions because and pop them in the chat and I'll pop them in as we go. But the more interactive, this is our chance to chat about stuff. So if you've got a client or something or a case, let's talk about it at the end. So Jen's going to present and then we'll have time for a discussion. So go for it, Jen.
It came up before, so here we go. I'll just find my slide. And can we see that? Can we see a hippopotamus? Please tell me we can see a hippopotamus.
Yes, I can.
Oh, there we go. Beautiful. Okay, so welcome to the world of nausea and vomiting. And this is a subject probably quite close to my heart in many ways because in my early career days in the wonderful world of oncology and palliative care, I did a 5-year stint at St Bart's in London in haematology oncology. And when I did my cancer nursing course there, my big subject that I did my final, it's not a thesis, but my great presentation one was ironically nausea and vomiting. So it's something, I feel like it's an old friend to go back and visit. And sometimes I get a bit sad because there's not been a heap of changes in that time, but it's actually nice to know that solid principles and good nursing still come to the fruition. So please, as Sarah said, I'm happy to take any questions, go down rabbit holes or whatever. I know we know what it is, but just a quick relook at the definitions so we are all on the same page. So nausea is the sensation that we feel like we're going to vomit, and the vomiting is the act of expelling the gastric contents out of our mouth, or my particular favourite, out one's nose. They are two very distinct symptoms. People can have nausea without vomiting. They can vomit without nausea. And I think sometimes that is something that gets lost in the system. And people often forget that. They assume that if you've got to have one to have the other, and that's certainly not true. So if we're going to look at nausea and vomiting, unfortunately, we've got to do a little bit of anatomy and physiology. And I'm going to apologise, it's a bit content heavy and hard to relate this to case studies and things to make it a bit more interesting. So I'll just go back to this. And this is a very, very simple representation of how it all works because we all remember our anatomy and physiology from our university or other days. But it is important, and it's a very simple thing about how many parts of our body are involved in the process, and that's the key to it. And that also comes down to being key when we're choosing antiemetics and how to treat people. And the most important part that's actually impacted is, of course, the brain. So did I skip 2 slides then? No, I didn't. That's good. So in the brain, we have got the vomiting centre. And I'm just going to see if I can get rid of you guys here. Sorry, because you're taking up too much of my screen. Oh, no, I've just done a goose. Apologies. How did I manage to get rid of my slides? Can you still see my slides?
You can.
Huh.
Can you go to view, Jen, up in the corner? Because sometimes view up in the corner gives you different options.
I can see me behind you. I can see my slides now. I just won't try to get rid of your beautiful faces. Okay, so the vomiting centre lives up in the brain and it's in the medulla oblongata. So this is down here. It's the treble cleft nearly. It's the bit in the brain that just lurks and joins into the spinal cord. And I think that's really relevant because a lot of the messages come up about nausea and vomiting come from down below in the body, and that's where it passes through. So it's quite a quick reaction time to what it's detected. It's also the functional centre for the heart and breathing, and it's got the ascending, descending, the ascending sensory and the descending motor tracts in it, and of course the cranial nerves run through it. In a heartbeat, we're not going to labour this too long, otherwise you could talk about this for about a week alone, realistically. So in the vomiting centre, this will pick up problems with raised intracranial pressure. So if you've got you've got a brain tumour there, if you've got brain mets, or if someone's had an intracranial bleed, this is our barometer to pick up raised pressure upstairs. It also can pick up if there's pharyngeal irritation via the glossopharyngeal nerve. And so that's often the nausea that's caused by someone having severe oral thrush. We've got stringy sputum. I don't do sputum, but hanging over the gag reflex, or they've got a tumour there. Motion sickness comes into play here, as well as another section of the brain, and our peripheral causes, because obviously we've got the autonomic nervous system running up and down through. And liver capsule stretch is also, which can be associated with nausea and vomiting, may also be reaction for that may also run through the vomiting centre. So she's a very important little piece of our brain. And so if we've got the gastrointestinal tract, which we just talked about, a lot of that can be impaired mobility. So if we've got a stomach that's been squashed by malignancy, a stomach that's been squashed by ascites, be it malignant ascites or ascites caused by end-stage cardiovascular disease, liver mets, it can delay gastric emptying. It just doesn't work the way it should. It gets a little bit sensitive, it's squashed down, it just doesn't want to work. You also can get stimulation through the GIT by large or small bowel blockage, be it partial or complete, and again, dysmobility. And so you've got your cancers can cause it, adhesions, general debility, constipation, and sometimes it's not uncommon to see an aging person who has got cardiovascular disease who ends up with an ischemic bowel because they get a blockage of those vessels. It's not an uncommon thing in our age population that people will die that way, and certainly nausea and vomiting leading into that can be the thing that triggers them to hospital, that they discover that they've got a section of necrotic gut or ischemic gut. So disease presence in the peritoneum can impact the GIT receptor, and the receptors just shoot up the sensory pathway, and we get a response, or the afferent pathway, and we get a response to that. So the chemo trigger zone, this is another really key piece of excitement, and that's the red zone. You can see my little fancy skull spinning around there. And what's important about that is where it sits in the brain, and the fact that the very tail end in there it sits in the CSF. So it's, and again, another good screening tool to actually see what's going on, see what toxins are in the CSF, see what's floating around the brain to then trigger a response to that. And it's a great evolutionary feature because it detects substances that our body doesn't want, so then makes us vomit, and that's protective. And it's also really for bloodstream, there's lots of capillaries packed around it. So again, it's got the good old dipstick going into the central pools to find out what's going on and whether the body needs to vomit to get rid of something, or indeed recognise that something's not good for me, send you with a nausea response so you stop eating or drinking whatever that particular thing is, because it might feel bad. So the causes that can be detected in the chemo trigger zone, or as it's more frequently called now, the postrema, the metabolic causes, so hypercalcemia. And these make sense if you think about it as being a little dipstick that's detecting, it's a little screening tool that's detecting these chemical changes. So hypercalcemia, polyuria, that can be there. You can get, obviously nausea and vomiting can be, but with all our other normal symptoms as well. We can have uremia, and I should have apologised in advance. I am actually on call, so if I do get a call, I might have to step up for a little bit. Apologies.
What was that? Was that your phone?
It was. It's one of the girls, so I'm going to actually just ignore her.
It's okay. I did forget to say at the start that Jen is on call, and I said to Jen she just take a call and we'll have a chat if she needs to take a call. So
I'll just send a text. Apologies. Email both of us.
Gave me a fright.
Sorry. I'm hoping, because it's medical on call for the district, so I'm hoping they'll be kind to me, because they've been most unkind the last 2 evenings. Anyway, touch wood. So the other thing that we can get picked up in this area is hyponatremia. It's also where sensitivity to medications can be detected, and that's what can cause our upsets with nausea and things like that. And of course, the great cytotoxic agents, chemotherapy, etc. And if we may have overindulged in alcohol, so we might get an irritated lining of our gut, but our brain doesn't like to be bathed in alcohol, so its presence is picked up by the chemo trigger zone, and we may vomit all that red wine that we've just inhaled. So, the cerebral cortex, again, yet another part of the brain, has a role in nausea and vomiting. And our cerebral cortex is responsible for high level processing of the brain. There's 4 lobes: frontal, temporal, parietal, and occipital. That's all the list of things that it's involved for. It's the core part of our brain that makes us in a lot of ways. But it also has an impact on nausea and vomiting. And part of that is the limbic system, which is living in there as well. It's responsible for memory, and it remembers unpleasant experiences, and it also remembers bad smells. And this is one of our evolutionary survival tactics, that it remembers something like, oh my God, the last time I ate the purple berry off that bush, I vomited. And so you see that, you have the memory, you go, oh, I feel sick. I'm sure I'm not the only one with a memory of maybe a certain alcoholic beverage may do that to you. When I used to work in chemo land in London, we used to have blue trays, the colour of the stripe at the bottom of this slide, and we put our chemo in that to take to the patient. And patients that would come back would see that blue tray, and that would be enough to stimulate an attack of nausea and vomiting. Or one of my colleagues saw someone in the supermarket, and that was enough. The poor lady saw Margaret and turned around and vomited because of her association with chemo. So that's this limbic system. It's the fight or flight response that's kicked in to keep us going. So the cortex is also associated with anxiety. And again, that's the worry that, oh my God, last time I had this antibiotics, I was sick. Last time when I've had chemotherapy, each time I've got sicker. It's that worry. It's the worry about treatment, the worry about life that can kick in and also induce nausea and vomiting. It's there for a good reason, but when it's been overly triggered just because of ill health interactions with the health systems, medications, it's a very difficult thing to trigger people out of. You can't talk yourself out of feeling sick, unfortunately. So if we're looking at all that, the treatment principles around nausea and vomiting is prevention is better than cure, which is why we often talk about pre-meal antiemetics and finding out what causes ill health so causes the nausea and vomiting and removing it from the regime. We need great assessment, and we need to understand where things are coming from, because that helps form treatment. And becoming really familiar with the patient's history and story. So not just making things up on the spot, because that tells us, whoops, I've just done that myself. That tells us about, oh gosh, I've done well today.
Right again.
Okay, that was my fault. I fiddled with something I shouldn't have. It tells us about what their current illness is, their comorbidities, and their whole story and what's going on. But we don't get to know that unless we've sat down and done a really, really good assessment. So assessment is listening to the patient a lot of the time. It's what our superpower is as palliative care nurses, is forming that connection and finding out what they've got to say about themselves. And it never ceases to amaze me in the 20 plus, 25 plus years I've been doing palliative care oncology, especially in palliative care, that sometimes we are the first person who has actually truly sat down and listened to their whole story about their symptoms and what meaning that and impact they have on their lives. And that if we are doing that every day, we're seeing our patients, we are doing exemplary jobs. And that's what I'm pretty sure you are all doing, because that's what makes us good at it. So we find out from their talking about what their possible triggers are. And often people can name them themselves. So it might be every time I take that blue tablet, I feel yuck. Every time, 5 days after chemotherapy, I always feel like this. So they actually know what their problem is. And so then you can work with them to get them through that purple patch when they're feeling miserable. It might be that their wife insists on cooking an extraordinarily large cooked meal 3 times a day, and that makes them feel unwell. It might be a certain movement. I know if I lie on my left side, my right side, I feel sick. It might be certain smells, and certainly if you've experienced often nausea and vomiting associated with pregnancy, often smells is something that comes up and still trigger you many, many years later. It's because of the limbic system. So that's what we need to know about. We need to work out what their cognition is. Where are they on the scale? Are they on fire? Are they talking to us? Are they fit and well? Or are they actually moving towards, is their Karnofsky low? Is their cognition getting a bit off? Were they moving towards end of life? What their disease burden is, what the associated symptoms are, because that will also help us form disease and work out how hard we need to treat this. What can we do? What's the benefit versus burden of treatment? And also any associated symptoms of thirst, pain, hiccups, and dysphagia. What else is there that can be contributing to the nausea and vomiting? The classic palliative care nurse, you check their bowels because they're nauseated. Everyone else in the generalist system thinks we're mad, but we all know that someone who's chock-a-block full of constipated poo and very constipated feels nauseated. If I had $5 for every patient I've worked that on across my career, like many of you, I shouldn't be working. I should be retired and living the high life, because it's a low-lying fruit that actually bears, unfortunately. So we want to know about the quality of it. And I did this talk with my team not long ago, and it's been really good getting the feedback from the team that when they say that someone's vomiting, they actually ask about the vomit now. So we want to know, is it undigested food? Is it well and truly digested food? Does it smell? Is it a large volume? What's happening around it? We connect all these dots up together. Is it just retching? Are they not vomiting, but they're actually retching and they're producing saliva that's coming out of their mouth? Is it actually not vomit at all? Is it regurgitation because they might have a blockage in their esophagus and what's coming down is just not going through and coming back up? And it's, you know, they just got that regurgitation of food, so it's not showing any proceeds towards digestion. How long does it last for? Is it what's the chunk of day that they lose? Is it persistent or intermittent? How intensive is it? We've got sometimes people, and I've known them with a bowel obstruction, a high up obstruction, that they know it's something that they do, but it's short and it's sharp, and they can bear having their morning coffee because they want the coffee, they want the hit, they want the ritual. So they'll put up with that 5 or 10 minutes of very intense vomiting afterwards because it's what they're getting out of the vomit as they go. What's associated with it? What's happening around them? Is there any sudden increase in abdominal pain and they're vomiting? Is it they've got a headache and they're vomiting? We won't know unless we ask the patient. And of course, the altered bowel habit, is that a problem with these patients? Is there a time of day factor? Many years ago, one of my colleagues who's now since retired told me a story about how she got a call for a patient up in the mountains with severe nausea, and she got there and he was fine, perky, talking, everything was fantastic in the house. The wife left the room to do something. Within 20 minutes, there was this awful waft of smell coming through the house, and that was it. He started retching, trying to vomit. It was awful. It turned out the wife was cooking up the bones for the greyhound dogs in the kitchen, and every time that smell would come through, that would set him off and vomit. So he didn't need an antiemetic. They needed a gas ring up at the shed to cook the bones. So just because they've got a symptom problem doesn't actually mean they need drugs to fix it. Sometimes it comes down to the circumstances that are triggering it. And that's what's important to find out with assessment. Any changes to taste, you know, if they've got a metallic taste in their mouth, if they've got renal failure, they've got no taste or food taste like soggy cardboard and just soggy stuff. Is it oral thrush? Joining all those little dots makes the difference. To be the detective that we are. When you look at them as physical exam, are they dehydrated? Check the mouth. Always check the mouth because it's, again, low-lying fruit. If someone's got oral thrush and you treat that, we all look like gods and goddesses of the discipline because the quality of life improvement is marked. Have they got a soft abdomen? Is it distended? Is it painful? What are their bowels doing? These are the things that we need to be checking. And if the bowels aren't going, how many days is it? And was it a decent movement? Did they feel satisfied afterwards? Was it soft? Was it hard? All those kinds of questions. And unfortunately, sometimes it means doing the good old PR, which is never something any of us want to do because we all feel it's invasive, but sometimes we've got no choice but to check that out as well. Are they septic? Do they have signs of infection? Is there any signs of liver or renal failure, hypercalcemia? Neurological signs. These are all the things that I think we do automatically when we often walk into a room of seeing a patient or a house. But it's when you put it together, it's all relevant to nausea and vomiting as well, not just pain or not just anything else. It's our full general assessment. And of course, relying our peacocks and getting the symptom assessment scores, Kanofsky, and anything else they throw at us at the time that might incorporate into the picture and give us the story that might be causing it. So then the big decision is, and what people always would like to know is then how do I use all that and then choose an antiemetic? And a lot of it comes down to where the nausea and vomitings come from. Where is it being triggered in the central nervous system? Where is it being triggered elsewhere in the body? Is it something in a peripheral site? Because from that, then you can actually decide to put them on an antiemetic that might have the best impact. Love this picture, and you've all got to study it. And at the end, Sarah is actually going to test you on all the answers. It is a very, very, very busy slide, and I appreciate that. But what it does tell us is that commonly used antiemetics and things we use for that, for nausea and vomiting, like benzos, what pathway, what neurotransmitter they're working on. So ondansetron, granisetron, and tropisotron, they work on the 5-HT3 receptors. And I am of an age, a vintage that remembers when these drugs were new. And before that, we only had high dose Maxilon to rely on. So they were a game changer, but in reality, they're only a game changer for post-chemo, post-surgery, and post-abdominal radiotherapy. We look at the dopamine receptors, D2, one of the dopamine receptors, it's where haloperidol does its best work, and we love its work. We look at also if it's got, there's other impacts on different systems as well, the histamine, the H receptors. The M stands for the muscarinic, the GABAs. There's so many things that play a part in treating nausea and vomiting. And if you look, it's the gastrointestinal. So it's the stretched stomach and things like that comes up the vomiting center and how it lands. It's a good slide to have a reference point, but I do know it's busy and all the rest of it. The other thing of note, and I think I've mentioned it further slides, is now the existence of a prepatent, which I can never say very well. That is not our bag in palliative care. It's a very specific post-chemo drug that only works on the neurokinin receptors and only works on that pathway. So it bears no interest for us in palliative care. And the reason why I mention it is because I am cynical, unfortunately, and I believe that some bright, shiny person has used it in oncology at some point will decide that they should try it in palliative care. It is not clinically indicated. There is nothing there that we should be introducing that for. And my all-time favourite for people who have refractory nausea and vomiting is levo, but we'll get this a little bit further in. So first line is simple, and it always depends on the cause. So we've got, first line options for treating nausea and vomiting, pretty bog standard presentation is looking at good old Maxilon or metclopramide or domperidone if they may be repat. They help empty out the tummy, people feel better on it, they can fit more food in, happy days. If they look like they've got a bit of more centrally driven nausea, it's the thought of food and everything that makes them want to chup, haloperidol is great. And I love a bit of haloperidol because it is cheap, it is cheerful, it is easily accessible. And I know that ondansetron is very much a crowd pleaser and favourite around a lot of people, but that costs $25 for a packet of 10. So if you put that across a tablet and someone's taking them 3 times a day, it becomes very expensive because it's not on PBS for general use. If they're having post-chemotherapy or radiotherapy, you can get an authority script for it, but not for every day. So I must admit, if someone's got some in the house and I don't have access to parentals, I'll get them to take it because you can pop it under their skin. Would I prescribe it? No. I've done it once or twice, but it's just not economically or viable. Plus, I'm sure if I've got everyone to put in the chat, what's Zofran or ondansetron's great big adverse effect is constipation. So if you're giving it to treat nausea and vomiting, and the nausea and vomiting is caused by constipation, you're just chasing your tail around. It's a vicious circle that we need to break. Second line treatment is standards, and this does vary from place to place, and it will vary from your prescribers. I will be the first to admit that, but cyclazine is a very good second line. I've seen people go to that over using haloperidol first. The problem with cyclazine, it's a very good drug, is it's not PBS listed. So to be able to access it, you've got to actually go through compassionate grounds, depending on how your health system works in your state. It might be able to be achieved through their hospital pharmacies, which is how I access cyclazine when I need it, because I can get it in bulk for cheap or nothing for the patients. Or there might be compassionate schemes that you can access through your state governments, but it's not readily available. You can buy it over the counter, but I think it's about $9 for a packet of 10 tablets, because it's also a very common travel sickness medication. Third line for refractory nausea and vomiting is always my favourite, because I got very familiar with it when I worked in the UK, is levomepromazine and Nozanan. I'm really happy to see in Australia over the last 10 to 15 years it's become more commonly used in palliative care, because it's a great drug. And if someone's got refractory nausea and vomiting and they're dying, it's also got the beautiful secondary thing of being quite sedating, so it calms the farm as well, and it's got some analgesic properties, so it's a good all-round drug. It's available through SAS, and to be honest, it again is a bit like cyclazine. You need to see how your local health services are able to access that for your patients. Dexamethasone's often can be a bit thrown around a bit for nausea and vomiting, and can be a great adjuvant. Again, we just need to have a look and see where someone's up to in their trajectory and what their disease is up to, and PPIs as well. So if the nausea is actually someone with really bad heartburn or gastritis, you need a PPI. You don't need these other things. So we go from there. It's all about our assessment. So gut causes, again, the Maxilon and domperidone speed up the gut. I've talked about a lot of this, but a lot of literature will say it's contraindicated in bowel obstruction. But If you've got someone with a partial bowel obstruction that's higher up, you can use it to keep them going. You get them to take the soft lows residue diet. You get them to take regular antiemetic, and we see if we can, and a bit of dexamethasone to reduce edema, and we see if we can keep them going. The PPIs I've talked about, it's all about finding out what the patient's up to in their unique circumstances to work out the plan. The side effects of Maxilon are very well documented, and the European Association of Palliative Care put a big piece of research out, I don't know, it must be 10 or 15 years ago, really discussing the side effects of Maxilon or metclopramide and how to be very aware of them and consider it. The akathisia or generalized restlessness, I think, is a symptom or an adverse effect of it that's often under-recognised, because people think they've got a generalized delirium instead. There is a portion of the population who cannot take Maxilon at night because they'll have restless legs all night and they can't settle and they can't sleep. There's also the more dramatic extrapyramidal side effects and tardive dyskinesia. So they are nasty side effects that people don't want. So central causes is where the dopamine is the most common transmitter, and that can be your hypercalcemias, your metabolics, and your medications that can cause it. Nausea might be worse with the smell of food. Haloperidol is your friend. Moving to cyclozine if you need. We don't often see Stematol unless it's got to do with motion disturbance, because Stematol and haloperidol, you don't use them together because you can get Parkinsonian side effects. You've got to be careful, and Stematol is not very good use under the skin. Always think of side effects. And if a medication's just starting and you know that you've got a GP to prescribe or your Palcare prescriber to prescribe these drugs, next time you visit, you keep a bit of an eyeball out. You know, what's changed? Are they suddenly restless now? Whoops, was that the Maxilon we've started, and working through it. So vestibular, which I just referred to, Stematol is our friend. So that's for poor patients, and I will say poor patients because I do think it's an awful thing with vertigo. So they move their head, or Meniere's on labyrinthitis. Sometimes it will happen with people with bony mets, cerebellar mets, but it's often nausea that's associated with dizziness or head movement changes. Stematol is the drug of choice, as I said. Some people think about promethazine, and of course haloperidol can be used. Not my favourite. Psychological is where the GABA receptors in the limbic system have been aroused, and it's the anxiety accompanied by nausea and vomiting. It's the anticipatory nausea that we treat about. It's the fear factor. It's the worry about things happening. And so a little bit of benzo goes a long way for these people. And certainly back in when I did chemo for a living, or if I hear about patients that are experiencing this, very much encourage them to take something preemptively before they seek treatment, because prevention is much better than cure. So intracranial pressure, you know, a space-occupying lesion via a tumour, or someone who's had a fair-sized stroke can raise intracranial pressure. Dexamethasone is our friend, plus or minus the haloperidol. Oh gosh, I've done it again. Going from there. So chemotherapy and radio-induced nausea, vomiting, we talked about ondansetron. It's used a lot, and it's great for that post-chemical insult, post-chemo, post-radio, post-surgery. Talking to my nurse practitioner friends who work in emergency department, they love Zofran, and they can't understand why I go, why would you put someone on that? Because we think about the constipation angle. I've talked about a aprepitant. These really aren't our bag, although I do note that there is some services and sites who will put ondansetron in syringe drivers. It's a prescriber preference, and it's certainly not a preference I do. I've actually never done that in 19 years of prescribing, and I'm not likely to unless there's some incredible research that comes out, because I think the constipation side effect and a headache actually in older people is not worth it. So the non-pharmacological treatments are out there.
Jen, sorry to interrupt you.
Hi, sorry.
No, you're good. You're doing a great job. I'm just going to put out there, if there's anyone with their microphone off, can you just have a quick look to double check that that's the case? And if there may be someone in the background of your house, Jen, that is doing some cooking or something and banging your pots.
No, there's not.
There's not. So there's someone lingering who doesn't have their microphone up. So turn your microphone off.
I've had a husband walk through the house, but no pots were disturbed, because I've done the hand signals outside of view going, no noise.
Right. So turn your microphones off, please. Continue, Jen.
Thank you. So non-pharm treatments, there is a real lack of data to support non-pharmacological treatments. There's just not much there. But what is there is the power of self-determination. And I don't think we can underestimate the ability that people feel that they're helping themselves and fixing themselves, because that truly has a role, that self-empowerment. There is some data around the use of turmeric for nausea and vomiting. There is some research that may support it. There's a lot of people who support the use of ginger, and there's lots of things in between that involve music therapy, relaxation, etc., etc. And it sounds, and I think it's great in theory, but some of those non-pharmacological treatments are quite difficult to do in palliative care land, or if someone's, you know, trying to live their best life, you can't suddenly lie down and meditate for that time. But if someone's doing that for themselves, I am their 100% member of their cheer club, cheerleading, to support them to do that in self-care, because I think sometimes we underestimate what that can do for their soul and their quality of life. Dietary modifications are, of course, really important. And, you know, within the region where I live, work and play, Griffith is in part of my area, and it's got a large Italian community. And for those who with that kind of ethnicity, it's looking at their food sizes, their cooked meals, and trying to, any of those cultures that love feeding people, trying to talk the carer down into smaller, more frequent meals, that not having to provide the big meal that you made when your husband was out in the tractor and things like that. Reducing food aromas. Consider if they can cook outside or cook at times where the patient or their carer, their family member might not be in the house. Having things already frozen and put to one side in the freezer. So if, you know, your loved one suddenly says, "Oh my God, I could do some egg and bacon pie." So the wife or the carer madly gets together and makes that pie, and by the time they get it on the table in front of someone, the urge that food's gone again. So I do, and as I'm sure most of you do as well, encourage to have food frozen in the freezer, small cup-sized portions of soup, stew, whatever their favourite thing is. So if they want it, you get it, and you're in the microwave and have it in front of them really quickly. Avoiding the spicy, fatty and highly salty foods, pre-meal antiemetics, and just for the carers, just encouraging them not to take the refusal of food serious, you know, as a personal insult. And I'm not the only one who's on this webinar today who's had instances where carers do take it very, very personally, that they love showing their love through food and nurturing people. And when that's taken away, they really take it personally, and they feel that they're a poor carer. They're not doing a good job, and it can really impact them. So some social work and carer support there is often really just as important as trying to treat our patients' nausea and vomiting. The other psychological strategies, which I think can work to a degree, like I said, the relaxation, meditation, deep breathing, distraction, it's whatever floats their boat. We all have views according to what we've seen with it, and certainly our life experience as well can impact on that. Like I said, there is no convincing evidence. It's just what the patients and families feel works. There is increasing stuff for acupuncture and acupressure. It can work, and I figure if people have got access to it and it doesn't cost them a small fortune, it might be worth a go. The acupressure seems to work more for movement-related nausea and vomiting, but if someone believes it's working for them, like I said, I'm not going to actually argue the point. I would support them doing that. And they're the other list of things. There's just so many alternate therapies out there. I struggle myself with the aromatherapy as being helpful, mainly because personal experience of having very, very bad nausea and vomiting with 2 pregnancies and being very smell affected. So I struggle with that one. For other people, if it works for them, hey, go for it. So to sum up, nausea and vomiting is incredibly underreported and undertreated symptom, but it has a huge impact on quality of life. And again, if I had money for every patient who said, no, the only thing is I feel sick all the time, I'm sick of vomiting, I feel miserable, and their life is so encompassed on that, and you fix their nausea and vomiting, and all of a sudden they discover that they've got really bad pain, just because the nausea and vomiting has been taking up so much space in their brain and their emotional status. The thing with cancer patients is we see them transition towards end of life, their nausea and vomiting can suddenly improve as their Karnofsky drops, because their body's under less pressure and they're not moving as much. Non-cancer patients can get worse with their nausea and vomiting towards end of life, and actually can be a sign that they're moving into the terminal phase. And for those who do a lot of work in aged care, it's probably really poorly recognised. We think pain is poorly recognised and treated in aged care facilities. Nausea and vomiting is probably worse. It's not even picked up upon to be even thought about being treated, unfortunately. We have a vital role as nurses in treating nausea and vomiting. And I'd actually say when it comes to palliative care as a whole, it's the palliative care is important. And I know I'm a prescriber, but the prescribing is a very small part of my role. And if I see someone with nausea and vomiting, it's my assessment skills that actually are probably way more important than my ability to pull out a script pad, because then I can give advice to the people. Whenever we treat, we look at benefit versus burden. Do we investigate? Do we not? Do we give fluids? Is fluids a good idea? And that can really come down to, for me, living where I live, how hot is it? Is it the middle of summer and we've got to run a 40+ degree days? It's coming up to Christmas and someone's actually obstructed their esophagus, but they want to get through Christmas. I'll set up subcut fluids. If it's in the middle of winter and that pressure's not on, I probably wouldn't bother. It's really taking that individual case-by-case basis. And that's me. That is one of my beautiful photos from around my district, some canola in the springtime. And the thing about nausea and vomiting is it's all about the patient and improving their quality of life. And I'm a very strong advocate of that, not just because of my work formally in haematology oncology and studying the subject. It's actually probably my personal experience of having bad, hyperemesis that makes me a passionate protector of it. That's me done, Miss Sarah.
Thanks, Jen. Thanks very, very much, Jen. Yeah, that's right. I can see lots of claps there. So that was great, Jen. Exactly what kind of we're all going about our clinical work. Just need a little refresher, and it was a good one too. So thank you, Jen. I have two things I wanted to say, and then if anyone's got questions while I'm saying them, pop them in the chat because that would be helpful. But one thing, I'm always thinking about how to rephrase things for patients, but also when I'm teaching other nurses. And I love the phrase that you had to describe the chemoreceptor trigger zone as a dipstick.
Yeah.
Live stream. I love that. I haven't heard that before, but I think that's ace. So thank you.
Well, I think it nearly looks like, you look at the picture too. I think the best picture I found when I was creating this PowerPoint was the fact that you could see where the tail went, and you just go, no wonder it's so vital. No wonder.
So I love that. I love that. So thank you for that. That was my learning. And then I guess my question for you, and you did touch on it. The patients that stick out in my mind for nausea and vomiting are the ones that have gone through all of the routine kind of, metoclopramide or haloperidol, and then maybe cyclizine, and then they're in, say, a rural hospitals where I'm thinking of one, and they've just got this horrendous bowel obstruction and they are miserable. You mentioned Levo. I just wondered if you'd talk a little bit more about that, because I think we can probably all picture that patient who is bowel obstructed and miserable. What are your go-tos there? I'd love you to talk a bit more about that.
Well, since we lost ranitidine out of the market, unfortunately, because it causes cancer, whoops. I'm sorry, that was very sarcastic. Apologies if I've offended anyone. When you think about palliative care's use of it, I find that ironic. Anyway, never mind, move on, Jen. I don't make the rules in this game. But when it comes down to it, if I've got someone obstructed, it's depending where they are on the trajectory and how close they are to death, because you can get someone who has got a bowel obstruction who is an ovarian cancer, for example, it's low down. If they take haloperidol for nausea, they're on dexamethasone, reduce edema, they can actually survive on a soft diet for many, many, many weeks, if not even a couple of months, and live quite well. And if they're not vomiting up or they only vomit once a day, for me, it's happy days. Again, the ones that obstructions are higher up that you're alluding to, and they're miserable because they're vomiting. And the big fear can often be, and I've had someone recently where they're actually vomiting fecal fluid. And that's it, Sarah. The look on your face says it all. It's cruel, and it's a dignity thing for me, because the smell, I can't imagine what that would taste in their mouth either. It's just revolting. And so with people like that I know are probably quite close to death, they're vomiting poo, is I look at using something like Levo, that one part of its qualities is it's a fantastic antiemetic. And I often describe it, and I'm wrong when I do it, but it's the best way I know how, is I describe it as souped up haloperidol. It's a different class of drug, but I actually describe it as that for generalists, so they can imagine what haloperidol is, and then they can imagine what that's like souped up, so to speak. So this is the top shelf version of it. And so it calms them down, but it also relieves that nausea, and at doses greater than 50 in a 24-hour period, it actually sedates. And so I have no qualms in having a very open conversation about needing to go to my top shelf antiemetic, and that the side effect will be that you may sleep for the rest of your days. And most people with that open, transparent approach are more than happy to sleep the last of their life away, to be honest.
Thanks,
and that
Jenny.
noise at the moment is my husband, and I apologise.
Okay. My other question with that is, so say you might put them on a syringe driver with Levo in it. Do you use then Levo as a PRN? And is there a max dose, or is that too specific a question?
No, it's not. A max dose in Australia is 200 in a 24-hour period. And so my general starting point is, depending again on my goal, if there's someone that I view this is a temporary glitch, I might, do divided doses. Yes, I'll get to that, Jess. Great one. There is a role there for divided doses and see how they react. But if it's someone close to death, I tend to have that probably more considerable conversation and happily start at 50 or 75. If they sleep, they sleep. They've been warned, and then they can just use the 12.5 to 25 milligrams. Excuse me for a second. Thank you. They can use that as a breakthrough, and then we can always escalate the dose the next day. We can always titrate like we do for anything else. The UK's top dose for levomepromazine is actually 300. And because I worked over there for so many years, and we can, as a prescriber, if you're confident and you can defend your clinical decision making, I haven't had to go much past 200, but every now and then it can be possible. But it's a lovely drug. Access, like I said, special access scheme, but which can be done online for any of those who are in the rural settings. And possibly I'm making an assumption, and I shouldn't, it might be as difficult for metro as potentially access. But I've tried and working very hard with our pharmacists to ensure there's a little supply at a lot of our sites. So there's always some within an hour of where most of my patients live. Does that answer? I love it. It's a great drug.
Yeah, and actually, on the patient I'm thinking of that was really terrible, like terribly distressed at that bowel destruction rurally in your region, you gave her Levo and she just settled, right? Like it went from distressed to calm, which was wonderful. Now, Jess has also mentioned in the chat there, have you got any thoughts about the role of an NG tube?
Yeah. I used to be honest, in my earlier days in palliative care as a nurse, I used to hate nasogastric tubes, hate them with a passion because they're so uncomfortable. But I certainly view that that it has a place in high up obstructions, so gastric outlet obstructions and things like that. I've actually put them in at home and done the checks for people who really didn't want to go into hospital and palliated them well. I figure, Jess, and for everyone, it's probably a bit of a trial and error job. Sometimes if they're low down and I can stop them and perhaps sedate them if it's a lower down obstruction, I won't. And sometimes if they're that close to death, I just can't. In my good conscience, the idea of popping one down when I can't get full informed consent, I can't. Interestingly, we had a mountain dweller in the last couple of years, and he had died of a higher up obstruction, and he would not allow us to do any intervention. He wanted a natural death, and that meant lots of vomiting, and we tried to convince that a nasogastric tube would be assisting that. And anyway, and when he was unable to speak for himself, his wife still advocated for that to happen. So he died of an obstruction which was high up without anything, and it was I found it very challenging for me, and I know I support patients' choice, but I did find that a challenge, to be honest.
Yeah, and that's actually probably a very good point to make, isn't it? That it's the point, you're doing this assessment, but really the most important part is what does the patient want, what matters to them.
Yep, their goals, their life goals. And I think probably now You see more people now, and I guess it's a bit like the other end of life, the birthing movement. There's more people who are trying for the so-called natural. And, you know, for me, I find that, I'll be the first to confess, and this is a personal view, I find that a little bit troublesome, because sometimes a little bit, you don't have to have a lot of drug. I'm not a big believer of heavy sedation or heavy use, but sometimes a little sprinkling of fairy dust can go a long way.
Yeah, thank you. So that answers my question, absolutely. We've probably got time for one more question. Has anyone got any nausea and vomiting related questions they'd like to ask? If we don't have another one, I've got one.
I do too, actually.
Oh, great.
Yeah, I do. I'm just curious because I know caring at home, if anyone else has got a question, shush me up because I'll be happy to. The caring at home, we're looking to put through labels for, unless the use in New South Wales, someone in New South Wales was looking to put through labels for Zofran to go on syringe drivers. And I'm just curious, is that why, you know, is it used widely? Am I just in my own little pocket of rural remoteness and don't look over the fence at what other people do? Has anyone got any experience of using it?
It's a nice, good spread of everyone here, so we should be able to get a good little.
I remain curious and without judgment, obviously.
Beck wrote something, but you're using it up in down in Catherine?
No, every now and then, because we get rotating doctors, every now and then some of them will come with the Zofran, but we mainly stick with metoclopramide, and we've definitely had 2 patients recently that have gone on Levo. And we now have our own supply in the pharmacy as well, which is great. What a big win.
Isn't that a lovely feeling? It's like you see them wrapped up in a warm blanket, and that it's the most beautiful sight seeing someone who's been struggling.
I couldn't believe the difference. We had a man in the nursing home, he was that distressed. And then the difference once we got him on the Levo was just beautiful. Yeah.
That's great news.
Oh, and Louisa said we use haloperidol. Jess says we use haloperidol. Maxine says not in the southern highlands of New South Wales. Linda says never. So I think
probably not. There must be just a couple little outcrops somewhere. Yes. You know, if I'm using a driver, prescribing a diver, to be honest, I don't tend to put Maxilon in because Maxilon stings and it takes up 2, 4 or 6 mu. Oh, Abdul, I'd like to talk to you about olanzapine because there's emerging, sorry to put you on the spot, but there is emerging evidence about using olanzapine and quetiapine even as for vomiting, nausea.
Abdul, are you there to unmute yourself? And actually, Jen, I've seen that used in at Greenie in Melbourne actually.
Yeah, hello.
Yeah, hello.
Yeah, hi.
Can you talk a little bit more about using olanzapine for nausea and vomiting?
Back in Singapore, when I was still with my doctors, they sometimes we give olanzapine because it has like a double effect for patients that have behavioral issues, you know. At the same time, we treat their nausea and vomiting because patients that usually have nausea and vomiting, they tend to be more restless, agitated. So Olanz helps to control not only the behaviors but also their nausea and vomiting. So that's why I've seen patients that on olanzapine, it helps them. I mean, yeah, they really do feel comfortable. And at the same time, if they have difficulty swallowing the pills itself, we would crush it and then we could and then we'll sublinguate it. And it's really, I think it's really helpful. Yeah.
Thanks for adding that, Abdul. That's very interesting. Sorry, Jen, go on.
No, I just looked up on PBS and I hope I didn't look like I was ignoring it. Unfortunately, only streamlined for schizophrenia and bipolar in Australia. So to actually get it would have to be private script or having someone who is happy to commit fraud, I suppose, for want of a better phrase, or access through a hospital. Yeah.
Okay. Well, thanks so much for adding that. Actually, that segues to one more thing I wanted to ask about, which was PBS and items that are on the PBS. I had, so just you mentioned it and I was too slow. There's so what's on the PBS? Metoclopramide and
haloperidol are on PBS.
Okay.
Yes, they're on PBS. And often, like Zofran, like I said, it's private script if it's for just general nausea and vomiting. So that's a financial factor. And as someone who's recommending, as palliative care nurses do, because we're specialists, and someone who, for me, who's a prescriber, I always look at the endpoint of cost, because if it's going to cost too much money, people aren't going to be compliant, especially these days when, well, the cost of being sick is humongous and everything has got so expensive. So they're on PBS, our cheap and cheerfuls, for either parental or for
Subcut.
tablets. Yep, tablets or subcut. Levo isn't actually that expensive, but it's SAS scheme, and I think most people actually gain access to it through hospitals, pharmacies, and it's a negotiation between palliative care services and the people who hold the purse strings. Okay. Apparently, I have a compassionate budget. I've never seen it, and it just seems to disappear onto that. And because it's used responsibly, I keep that right. Cyclazine is ampules, I think, are on.
I'm putting it on the spot.
SAS, yes. Ampules, I think, by memory. I always have to look up because I don't prescribe it as often. I think ampules are on PBS, but tablets aren't. Even though you can buy it in big quantities in New Zealand over the counter, we don't have that access in Australia.
All right. That's super helpful, Jen. Look, thank you so much.
Right. I hope that answers some questions. Anyone? Yeah. Hope that's and hope no one's gone please.
No one has left. I'm always watching to see if anyone leaves halfway through, or I'm watching, but no one left. So everyone's still here, so that's good. Sorry, now you know I'm watching. Jen, that was really, really great. And I think for palliative care nurses around Australia, just going about their business, nice to have a little refresher, and a good one too. So we're very lucky to have you, Jen. So thank you very much.
No worries.
And I think the next webinar, before everyone leaves, the next webinar is about palliative care for patients who are living in group homes, living homes, and it's going to be a ripper, because they were going to get someone from a group home who works in one to give us a bit of perspective about how to make it happen. Yeah, so come to that one too.
Yeah, I will actually, because that'll be it's such an area of need that's so underserviced.
All right. Well, look, have a lovely afternoon. Thank you very much, Jen, and bye-bye, everybody.
Bye. Take care, everyone. Stay safe. Be well.
Thank you.